Good morning. Welcome to Module 1C, in which we will be talking about the Student Health Index. So my name is Lily Nienstedt, and I am a doctoral candidate at Vanderbilt University. And I've been a consultant with the California School-Based Health Alliance for a few years now, and have worked on the CSHA in collaboration with the team. Just a little overview. The California School-Based Health Alliance is a statewide nonprofit organization that is dedicated to improving the health and academic success of children and youth by advancing school health. And they do this in a number of different ways. They help new school-based health centers get started by providing them tools and resources and guidance, and they help them bring together partners who can work together for their school-based health and wellness centers. They also help existing school-based health centers to grow and to improve and to incorporate best practices that can help sustain their services. And they do this in a lot of different ways through convenings, as well as an annual conference and tools that you can find on their website. They're also a member organization. And so if you're not a member of CSHA, we highly encourage you to become a member, especially if you have a school-based health and wellness center, or if you're planning to open one. The membership provides discounts to the annual conference, as well as some extra technical assistance. But all of the resources that you'll find on the website are free, and we want to spread them widely, including the resource I'll be discussing today. So again, this webinar is part of a series on school-based health and wellness centers and evidence-based models for integrating school support. And what I'm presenting today is part of the first module called Introduction to School-Based Health and Wellness Centers. Specifically, this webinar will introduce you to the California Student Health Index, which we've developed over the last few years. And so the learning objectives for today are that you will be able to use data-driven tools to help identify opportunities to improve access to care at schools in California. I will provide an overview of how to use the Student Health Index, which we call the CSHA, to determine where to advocate for school-based health and wellness centers. And I will describe some key findings of the CSHA. So before I start, what is the CSHA? The CSHA, or Student Health Index, is the first statewide comprehensive analysis to identify the counties, districts, and schools where new school-based health centers will have the greatest return on investment for improving student health and educational equity. As the COVID crisis laid bare, Californians across the state are faced with serious inequities in their access to healthcare and health outcomes. Because health and education are reciprocally related, these gaps impact young Californians' educational experiences as well. For this reason, the Center for Disease Control's Community Preventative Services Task Force has recommended the implementation and maintenance of school-based health centers in low-income communities, based on evidence that these centers promote health equity and improve educational outcomes, especially for low-income populations. We know that some schools need access to care more than others. And so the aim of this project was to gather, analyze, and provide you with the data you can use to make informed decisions about which schools, districts, or even counties have need for additional support. So as of this presentation, there were over 400 school-based health centers active across California. But there are also over 10,000 schools in California, meaning that many students and schools do not have access to school-based care. And so the CSHA is supposed to help identify opportunities to improve that access. As we are all thinking about where to advocate for additional school-based health centers, where to expand school-based health centers, and what services to provide, there is a variety of evidence that we use to make those decisions. There's clearly qualitative evidence of need, and that usually comes from conversations with stakeholders, conversations with people at schools, conversations with youth and their parents, and can be done generally most easily at the local level through community partnership. And then what we're trying to provide is more evidence on sort of the quantitative side, using metrics and publicly available administrative data to provide evidence that CSHA and partners can use to assess the need for school-based health centers to serve California students more equitably. And then, of course, there's also the part on feasibility, community buy-in, and finances. which the CSHA is also able to provide assistance with. And this webinar is not about that, but there are others that go more into detail on that. The goal of today and the goal of the SHI was to take advantage of evidence and quantitative data that already exists, that the state is already collecting and reporting, to create the School Health Index. So the objectives of the index were to construct this SHI, which can assess the need for school-based health centers and wellness centers across California. And based on these metrics, identify schools and districts that have the greatest relative need for additional school-based health centers. And so to do this, I developed a set of inclusion and exclusion criteria to limit the number of schools I analyzed. And then I selected data. So I developed the relative need index by conducting an analysis of similar indices, interviewing researchers at UCSF, as well as folks at the LA Trust, and analyzing literature on school-based health center outcomes. In partnership with the CSHA, I then selected indicators that were available publicly and created the School Health Index. To do this, I combined the indicators by merging and spatially linking multiple data sets that are available in California, rescaling the indicators to be able to compare them across schools and districts and counties, and then calculating what I call the relative need score, which allows us to identify schools that are relatively in more need of additional supports than others. And lastly, I rendered this data usable for the public and for internal use. And I'll share a little bit more about the data dashboard, but it's already available on our website and will be linked in this presentation as well. So not every single school is included in the School Health Index. We excluded virtual instruction schools that are primarily or completely virtual, because it would be difficult to have a school health center at a school that's virtual. We excluded very small schools, so schools with enrollments under 100 students. And then we excluded certain special educational option schools, such as schools that serve only adults, youth authority facilities, and county community schools, as well as preschools. This analysis is focused on schools serving at least grades 1 through 12, although some of the schools do include preschools. Using those criteria, we identified over 5,000 public schools that were selected for the analysis. Over 8,000 public schools that were selected for the analysis. Schools with existing school-based health centers are included in the index, and these schools can be filtered out of the online resources, and the data can be looked at in accordance with data users' interests and needs. Additionally, the complete data set with all 8,000 schools and all the data points about them is included in the index and is available for download. So as we were choosing the data points to include in our SHI, I created a set of criteria for evaluating every data point. So the most important one was that the data be publicly available. I wanted this index to be reproducible, so using data that is available and up to date was really key to this project. The data points also needed to be relevant. The indicator needed to be suggestive of high need for additional health care or suggestive of specific health services that school-based health centers can provide. And all of that was supported by the literature on school-based health centers. I also wanted the evidence to be non-duplicative. So multiple indicators may tell the same story. For example, poverty rates and income rates may not both need to be included. And as such, the most salient indicator had to be selected. And then lastly, where possible, I wanted the indicators to be geographically specific. They needed to be chosen to hone in on the geographic area around a school as closely as possible. Of course, data about the actual students that attend the school would be most effective, but we don't collect a lot of health and income data at the school level. So census tract level data was used in those cases. And census tract data was used over county level data because county level data is not super useful when we're thinking about schools across a really large county. It was also important that the data be available for the entire state. So even though perhaps some counties collect a ton more data than others, those variables were not included, even though they might have been interesting and relevant because not every county in the state collected them. I completed an analysis of the landscape of existing indices, including the California Healthy Places Index, Colorado's Health Institute's needs assessment for school-based health centers, and work that the LA Trust has done in LAUSD, as well as the National School-Based Health Alliance's Children's Health and Educational Mapping Tool. And all of these were models for the SHI. Together with the CSHA team, we decided to focus on indicators that told us something about health and healthcare. This included data on asthma, teen pregnancy, and proxies for physical activity, and were collected primarily at the census tract level. Socioeconomic indicators, which represented each school's underlying community characteristics, these were also collected at the census tract level. And then school level demographics and outcomes, which allows for the inclusion of demographic characteristics at the individual school level that serve as proxies for hunger rates, as well as detention and disciplinary concerns. And these were collected at the school level. So again, this inclusion of these criteria was driven by literature reviews and was based on indicators that school-based health centers have been shown to impact, and were also impacted by data availability. So here you can see an overview of the metrics we ended up including. So for health and healthcare, we use the diabetes rate at the census tract, the asthma emergency department admissions rate at the census tract, the teen birth rate at the census tract, and whether or not a census tract is considered a health professional shortage area. For socioeconomics, we included poverty among individuals under 18, uninsured rates among individuals under 19, and the California Healthy Places Index. All of these are collected at the census tract. And then at the school level, we included students eligible for free and reduced price lunches, the percent of English learners, the percent of chronically absent students, the percent of homeless students, and the school suspension rate. The UCSF Health Atlas was hugely helpful in obtaining census tract level data, and the school level indicators came from the California Department of Education. I spatially linked the census tract level data to each school and assigned the school its underlying census tract data. There are, of course, important limitations here. Students don't necessarily attend a school in their census tract. I wish there were more of this data collected at the school level, but for the purpose of this project, this was the most geographically specific data we could get. We also really wanted to include data on mental health. However, there really wasn't any publicly available data that was geographically specific. In the dashboard, you can see the mental health hospitalization rate for each school, but that's really the county level rate. So this is not collected at a very geographically specific level, and thus it's included for analysis and for data users to see, but it doesn't contribute to the calculation methodology. Similarly, the percent in foster care is included, but because these numbers are very, very low for the majority of schools, they were not included in the final calculation. The original SHI was developed in 2021, and I updated it this past year with 2 new metrics. All school data now reflect the 2021-22 school year, which was the most recently available data from the California Department of Education. And we added the percent of households with no vehicle in a census tract to get at measures of transportation feasibility, as well as the COVID vaccination rate by zip code. So now we have these 14 different indicators or data points for each school, and we had to figure out a way to calculate and determine which schools were highest need based on these indicators. It was important for me that this need score be relative, meaning it compares every school in California to every other school in California. We at the CSHA did not want to set a threshold for any given indicator because we do not feel that there's a target rate of suspensions or asthma that one can reach that would lead us to decide, oh, this school is doing well. Instead, we wanted users to be able to compare their school to other schools and decide for themselves which metrics are uniquely important or concerning to them. For this reason, what we did is we ranked each school according to each metric. So for example, let's take asthma rates. I figured out which percentile of asthma rates a school fell into compared to the rest of the state. So if a school had an asthma rate that put it in the 4th quartile, meaning the asthma rates were in the top 25% of asthma rates across the whole state, we gave the school a score of 4 for its asthma metric, meaning it was highest need on the asthma score. We did this across all 14 indicators. A school that placed in the 4th quartile for all data points, meaning highest rates of suspension, highest rates of asthma, highest rates of diabetes, highest rates of poverty, would then receive a score combined of 56, which is 14 times 4, which would be a very high need score. And not that many schools actually achieved a score of 56. Across all of the scores, the top 25% of schools with the highest need scores were assigned highest need schools. This also means the schools assigned as lowest need schools just fall in the bottom 25% of the state. That does not necessarily mean that they don't have need. It just means that relative to other schools in California, they score better on these indicators. So just to give you a brief example of how to use the SHI, I'm going to switch my screen here. And show you our website. So here's the website, which is also linked. And if you scroll all the way down, you'll see the Student Health Index, which is now refreshing. So you can make this full screen. And then you can zoom in and out of different counties in the state and into different cities. You can filter out the data up here on the right. So say I only want to see our highest need schools. I will check highest need, and it will only show me those schools. Say I want to filter down to just Alameda County. I select that here and it will zoom in. And then say I only want to see schools in Oakland Unified. I will click that and it will zoom in. Say I only want to see elementary schools. I will check only elementary schools. I can also filter by enrollment and whether or not the schools already have a school-based health center. I can then click on a school and see the metrics about it. I see the name of the school, whether it got what its need school is, its school type, its district, its county, the number of students enrolled in the 2021-22 school year, the percent of students that identified as non-white and non-Hispanic, whether or not it's a charter school, whether or not it's urban, and whether or not it currently has a school-based health center. And then here I can see all of these metrics about the school. So for example, at this school, 92.4% of students were eligible for free and reduced price lunch. This compares to the California average right here. So on average, across all California schools, 61% of students are eligible for free and reduced price lunch. Similarly, this school is in a census tract where per 10,000 people, 114 people went to the emergency department for asthma. And that compares to the average across the state, which is only at about 54 people. So almost over double. Switching back to my slides. Oops. Just a couple key findings from the SHI. Across the state, our highest need schools serve the majority low-income and non-white students. On average, the schools enroll 90% students of color and 87% students eligible for free and reduced price lunch. These high need schools are also concentrated in certain areas. So zooming in here on Los Angeles, we can see this really high concentration of red dots in certain parts of the city. We can also look at counties and districts. So to do this, I look at both the numbers of schools in a county and the number of schools marked highest need in that county. And the ratio of that shows us what percent of schools in a county are marked as highest need. So here you can see Lake, Madeira, Imperial, and San Bernardino, as well as these other 10 counties have very, very high rates where almost or over half of all the schools in the county are marked as highest need based on our indicators. Similarly, there are districts in the state that have over 90% of their schools flagged as high need. So for example, Linwood Unified has 18 included schools and all 18 schools were flagged as highest need. Additionally, existing school-based health centers, here marked in blue on the map, are located on average at higher need schools, but not consistently at the highest need school. This could be a good thing because it could mean that school-based health centers have already brought those metrics down, and so those schools are no longer being marked as highest need. But it could also indicate that there's significant unmet need at schools that could really benefit from these health centers. So just to summarize our findings, importantly, there are some data limitations that cannot be addressed without differential statewide data collection and reporting. In particular, we just don't have any data on student mental health that's being collected at the state level. Of course, many schools and districts are collecting this data, and they can use that data to supplement our findings. Additionally, currently existing school-based health centers are located at high need schools, but not always at the highest need schools, meaning there's a lot of unmet need across the state. Race was highly correlated with the relative need score of a school, even though race was not included in any of our metrics. And lastly, there are districts and counties with significant levels of unmet need. So for future needs and recommendations, we obviously support the creation of additional school-based health centers. We also support and advocate for more data collection for better state and school level health data, especially related to mental health. And lastly, this dashboard can be used to advocate for more state level funding for school-based health centers. And we hope that you will think about partnering with CSHA. And I talked about this at the top of the presentation, but please reach out if you don't already have a school-based health center about touring one, learning about potential partnerships, getting help selecting a model that best fits your need, and receiving guidance as well as access to our startup toolkit. As you're thinking about where to begin, there's a couple of resources here. On the left, our QR code will just take you to our website. That will also link you to the Student Health Index. So please use that to identify schools in your region that could benefit from additional support. Download our report on Vision to Reality and start planning your school-based health center. So finally, at CSHA, we are here for you. We want to help you in your work. We want to help you find health partners, launch health services to figure out the financing and the operations and information sharing laws and all sorts of logistics for getting this up and set running. There's 3 specific resources on the right, and the QR code and the website link you to a page that gives you all of our CSHA's most important and helpful resources. You can also reach out to CSHA at any point and come to our conference, register for our webinars, and see if we have a regional convening near you. Please ask for what you might need because we would love to support you. Please also follow us on social media and stay connected, and feel free also to email me. My information is here. Thank you so much.